So small cell lung cancer accounts for about 13 to 15% of all lung cancer diagnoses. And by definition, it's considered an orphan cancer because it's less common. It is an area in which there's been tremendous need to improve outcome. Historically, therapies were platinum and etoposide given for between 4 and 6 cycles. There have been significant efforts to improve outcome, so intensification of therapy. There even early, several decades ago, we even looked at doing transplant in this population of patients. Unfortunately, this is a cancer in which relapse is common, in which even though we see a significant response rate and significant improvement in symptomatic burden of disease with response rates between 70 to even 80% for many patients. This cancer is one that can be relentless and can relapse quite quickly. So efforts have looked at giving multiple agents, so intensification. It's looked at stem cell transplant. Therapies that have also been looked at are addition of longer therapies or switch maintenance or continuation maintenance for these drugs. With carboplatin etoposide, these drugs tend to be quite myelosuppressive, so subsequent therapy can sometimes pose challenges, but bringing drugs like topotecan earlier to maintenance have proven to be ineffective. If we look at what's happened in the past decades, we can think of at least 60 phase 3 trials that have been negative in small cell lung cancer in early disease, and that's with using different oral agents, different VEGF inhibitors, 2 versus 3 drugs, and we really haven't made significant impact. What we've seen is that response rates might be higher, that progression-free survival will be better in giving continuation therapy, but there's been very little impact in overall survival. Efforts that have improved overall survival include radiation for subsets of patients, so chest RT. That comes with toxicity, and there's variable uptake among centers and who would be appropriate for chest RT. And then PCI, we felt could improve survival in patients with extensive stage disease, but earlier or later confirmatory trials from Japan demonstrated no improvement in OS, perhaps a change in PFS. In both the Caspian trial and in Power 133, we see that overall survival is improved. We look at progression-free survival, there's not a significant improvement or such a large delta in that space. It's a smaller hazard ratio. And we talk about response rates with immunotherapy and chemotherapy being not significantly higher than chemotherapy alone. Again, this is a cancer that tends to be chemotherapy responsive. But when we talk to a patient about what treatment looks like, and we sort of begin that journey for what therapy will be like over the next months, one thing we communicate very early on is this is a difficult cancer, and that likely therapy will be ongoing. There may be periods in which we take treatment breaks, but this is a cancer in which relapse is common. I think we would talk about these 2 phase 2 trials and this clear evidence that immunotherapy improves outcome. Although the difference in overall survival is modest, is less than 3 months, what I can say very clearly is a proportion of patients who are alive and have minimal burden of disease at 12 and 18 months is significantly better with immunotherapy. I think that's important to communicate to patients. So even though PFS doesn't look that different, if we look numerically at the number of patients who have recurrent disease or progressive disease, that's less. Moreover, the addition of immunotherapy to chemotherapy does not increase toxicity, so it's well tolerated. And so this idea of more therapy or intensification with 3 drugs, to me, makes good sense. There's a chance that this patient could live longer. There's a chance that this patient could really benefit from upfront immunotherapy and develop stable disease at 12 and 18 months to get to those milestones that are important for her without a risk of significantly increased toxicity.